Good morning all. I'll be discussing on surgical steps of laparoscopic right radical nephrectomy. This was done for a large RCC. It was around 10 cm in size, arising from the lower pole and extending till the renal hilum. It was more anterior in location. So the patient is in left lateral position. I usually prefer standard laparoscopic ports. The camera and the right hand port being in the paramedian line. The left hand port is couple of centimeters lateral. I prefer an extra port. It is around 2 cm above and medial to the iliac crest. In right-sided cases, a liver retractor port is required. It is just few centimeter below the sternum based on the location of the liver. So the arrow was showing the liver. The foremost step of the procedure is to understand the anatomy of the abdomen from cranial to see the lower lip of the liver, how the colon is positioned, are there any adhesions or not. The bulge on the lateral side is the tumor. The appendix as marked is little bit pulled up cranially. That seems to be the colon. Now proceeding with the surgery, if there are some adhesions, usually the first step is to remove those adhesions. I tend to use intestine holding forceps on my left hand and the thunder bit on my right hand. So our left hand would always have an atraumatic instrument if possible. We should make a habit to use our left hand instrument as much as possible. I, being a right-handed surgeon, my right hand is dominant, but I keep in my mind that I try to use the left hand as much as possible. There is a little bit of adhesions. We need not release the lateral side too much. For reflecting the colon, lift the peritoneum with the left hand and make a cut with the right hand. Now once that cut is made, you can try to find a plane beneath that cut, both cranially and caudally. But it should not be very deep. Try to have layer by layer opening of the peritoneum. Normally, the lower lobe of the liver is quite free and can easily be retracted. However, in this case, there seems to be having some adhesions. The opening of the peritoneum which we have made should be continued cranially and caudally, and it should be till the lateral wall of the abdomen. So that is open till the lateral wall. Now the same incision can be followed caudally. So you can see I kept on buzzing some small blood vessels. I wanted the fill to be very clear during the procedure. The appendix is there. I am trying to release the appendix and push it caudally. You can see a small vessel just beneath it, and I coagulated it. The appendix seems to be released. It is always better to have smaller movements of the instruments because a wider movement sometimes can lead to bleeding. The left hand retraction here is very important. So I try to keep the bowel retracted with the left hand and keep on cutting the small fascias. So you can see a small bleeder coming from the posterior part of the intestine. Since it might be closer to the posterior wall of the intestine, I didn't want to buzz it blindly. It is always better to have a proper look at the bleeder and use the minimum amount of cautery for coagulating it. Now, as I told before, I wanted to have a very clear vision, but such a small bleeder has led to some collection of the blood there, and that might not be the best of the view you would have expected during the early phase of the surgery. But it should be fine, and it's always better to have a better look at the bleeder and hold it and coagulate it instead of blind coagulation. It seems to have stopped, and the release of intestine is continued caudally. So these incisions which we make on the white line of the tool are a little bit tricky, and they are very important also. If our incisions are quite deeper and we are pushing deeper tissues, then the ureter and gonadal vein might also get pushed medially along with the colon. On the other side, if our incisions are very superficial, then while pushing the colon away, the posterior part of the colon or the posterior mesentery might still be there attached to the lateral wall. However, they can be pushed again later. So it is always better to make the incisions as superficial and have thinner cuts initially, and we can always go a little bit deeper if required. As this tissue might differ from patient to patient because the fat might differ from everyone. I am continuing the retraction of the colon caudally. In cases like this, where the tumor is quite large, it is always better to have the colonic reflection from the lower lip of the liver to almost the pelvic inlet. This wider reflection of the colon will give a better understanding of the anatomy. Here we are almost done with our colonic reflection caudally. Some haziness of the camera. A practical tip is not to connect the pneumo with the camera port. Better to connect with the working port. It will avoid frequent haziness of the camera. Continuing the same reflection of the colon cranially. It will move the colon away and also release some adhesions from the liver. Unlike ligature, one of the jaw of Thunderbit is hot, and so you can see me touching the hot jaw on and off to the tissue around just to avoid the thermal injury to the important structures around like liver or colon. The liver port is inserted. Now we can use a tooth forceps to retract the lower lip of the liver and fix it to the surface of the lateral wall. After inserting, I felt a little bit more adhesions are required to be removed. As you can see, I have left a thin layer of the fascia on the liver. It was significantly attached to the liver. If we try to separate it, there might be some oozing from the liver. So it is safer to go just beneath that layer and get a plane till the lateral wall. I'm inserting an auspice now. Usually it is not required in majority of the cases. Since I wanted a better vision here, considering the difficult anatomy, this auspice is radio tagged. That means there is a radio opaque line which we can see in C-arm in case if we miss it. Also for safety, I have tied an suture at the end of the auspice, which I will bring out from one of our ports, and the suture being outside the abdomen will remind us that we have a auspice in. You can see I have a bleeder there, but I would not like to coagulate it blindly as it is quite close to the intestine. We can just compress it with the auspice for some time period and relook it back if it is constantly bleeding. So as such, a laparoscopic nephrectomy is divided into 3 phases. In phase 1, we retract the colon and duodenum. In phase 2, we create a window beneath the ureter and gonadal vein. And in phase 3, we get a Hilar control. So right now we are in phase 1 of the procedure. How do we get to push the colon and duodenum is we make small incisions in the fascia lateral to the bowel, and we get a good plane and try to keep on pushing the intestine medially. So fascias are the thing which we need to cut, and the rest of the tissues can be teased and pushed away. So the left hand helps in the retraction and the right hand does the cutting using the electrocautery machines. And we always try to do it layer by layer instead of going very deep. And once we have opened a layer, we should always complete it laterally, both cranially and caudally. Now, that is probably the gonadal vein. However, it could be one of the veins supplying the tumor also, because the tumor is quite big here, and the superficial veins will also be big. So I just opened a ureter layer over the gonadal vein. You can see the difference in the color of fat. That greenish thing is the ureteric catheter. We have a ureteric catheter in the ureter. I would always suggest to keep ureteric catheter in your initial cases, or in cases which are a little difficult. It will help you in easy dissection of the ureter. Once you have identified the ureter, the next step is to lift the ureter with the left hand and try to dissect beneath the ureter in search of psoas muscle. So that is the psoas muscle as marked. We would try to preserve the fascia, the shiny fascia over the psoas muscle, as there are nerves in the muscle fibers, and we would try to avoid injuring those nerves. You can see we have more facial layers over the kidney. In most of the cases, these facial layers will be less. Here, because of the perinephric wet stranding, we have more layers. It is always better to be patient and keep on opening these layers one after another. This is another opening on the ureter. Now we already have a window at the caudal part of the kidney. We can just connect both these windows. You can see the gonadal vein at the lower lip of the window. The easiest way to proceed for the hilar dissection now is to keep the lift of the ureter with the left hand. It will keep the whole kidney away from the inferior vena cava. Then dissect the intervening tissue vertically, strand by strand, and keep on controlling it. We should make an habit that we are not cutting or cauterizing a thick tissue together, because we might have some accessory arterial supply to the kidney. So better to always dissect the tissues strand by strand as thin as possible and to control it. The retraction by the left hand plays a very important role in this dissection. Because of the size and weight of the tumor, we have less space between the inferior vena cava and the kidney. There seems to be some oozing from the superficial veins. No, larger veins are expected when the tumor is big, and sometimes a little traction from one of the instrument can also lead to bleeding from the vein. there is some bleeding from one of the superficial vein. We can just dissect it better if possible and can clip it off. That seems to be the renal vein. Some tissue is adherent on the surface of the renal vein. We can tease it gently, and that is the upper part of the renal vein. I always use an intestine holding forceps in the left hand because sometimes a sharp instrument like a Maryland can injure some of the vessel, which can lead to more bleeding. And an electrocautery on the right hand or an suction on the right hand. Because of the limited space between the vena cava and the kidney, it was a little difficult to search for the renal artery here. I thought that if I can get the artery in between the aortocaval groove, we can control the artery from there, and so we tried to dissect in that area. So there are various ways to approach the renal hilum. One way is to just in a standard way to create a window at the lower pole of the kidney and follow and narrow that window towards the hilum and search for the renal artery and renal vein. Another way to approach renal hilum is to dissect in the interaortocaval groove and get the control of the artery in the groove. Another option, in case it is difficult, is to completely mobilize the kidney and flip the kidney medially and approach the hilum from the posterior part of the kidney. Now this is the dissection which is happening in the interaortocaval groove. We are on the surface of the inferior vena cava. We tried to see medial to the inferior vena cava if we can see any artery passing through there, but we could not see the artery there. Since it was not possible to get the renal artery in the aortocaval groove, we decided to continue the dissection and try to mobilize the kidney all around and flip it and try to approach the renal artery from the posterior part of the kidney. Now I realized that when I mobilized the kidney all around, it became a little bit easier to do some further dissection around the renal vein and try and look for the renal artery. The easiest way to dissect in the renal hilum is to have a vertical movements on the tissue surrounding the vein and the artery and to divide it into thin strands and cut it. And better to use an atraumatic instrument for this dissection, like an intestine holding forceps or an suction. it seems probably the renal artery is there. There will always be some lymphatic tissue around the renal artery, which we can tease and separate and can control with the electrocautery. Always better to have an habit of skeletonizing the renal artery and renal vein completely instead of leaving some tissues around, because the tissues might come on your way of putting the clips. We usually prefer putting at least 2 clips on the renal artery and 3 clips on the renal vein. If there is not enough space, 2 clips on the renal vein should suffice. This surgical video is particularly important as in this case we have used or we have tried various methods to get a hilar control, like trying to dissecting in the interaortocaval groove and completely mobilizing the kidney all around. The dissection is almost complete. The kidney is mobilized and only left on ureter now. The ureteric catheter is removed and the ureter cut. A quick look for hemostasis is done and a Surgicel is placed. We prefer to put a 24 French abdominal drain and retrieve the specimen via appropriate size incision.